Hello everyone, welcome to today's live session. My name is AM and this is Pre-Health Shadowing. We're an international student-led, woman-led, minority-led nonprofit for medical advancement. And we do have closed captioning. You'll probably be able to see it down below as I'm speaking to accommodate all students with all abilities and needs. And if you have any ideas about how it can be more accessible, you can go ahead and email us at info@prehealthshadowing.com. And you could save us as a contact to keep us out of your spam, as well as joining our email list so you don't have to miss any of our upcoming sessions. And if you want to go ahead and stay in the loop, you can follow our Instagram and TikTok. Both our tags are Pre-Health Shadowing. We post a lot of our events as well as activities that we have. Because we host from all over the world, you can go ahead and put in the chat where you're calling from right now. I'm currently in Northern California, so I'll be checking the chat. It's kind of a fun activity as well. And if you're interested in being part of Pre-Health Shadowing, we're always accepting student volunteers, and we'll be having somebody from our team, our co-host, go ahead and put the links into the chat so you can go ahead and join it. We also have availabilities for team members as of right now. And here are some of the positions right now. So we have IT department, lead of grants, and so much more. And this is what the application is going to look like. And all you do is go to the volunteering tab and click on join team, and you should be able to find this. And if you're a high school student, you can go ahead and join our high school training program. And we offer leadership plus healthcare education for pre-college learners. And this link is also going to be inserted in the chat. If you're looking to get published, whether it be articles, reflections, reviews, and success stories, you can go ahead and submit your writing to our submission section. That will also be put in the chat. And if you can, we would highly appreciate if you can donate, because we do solely run off of the time of our volunteers as well as the donations that we receive. So over here is this QR code that I will also be showing in the end of this presentation. Make sure to type your questions in the chat. If it's maintenance-wise, I or my co-host will be able to help them. But if it's something related to the presentation, we save our Q&A towards the end. Take good notes. Our post-shadowing assessment is available to earn a certificate verifying your hours on our professionals course page at Pre-Health Shadowing. And please have your cameras on because this is going to help create a shadowing experience. And yeah, before we end it, I just wanted to mention that we have a zero tolerance rule. So if some of you guys are not able to respect other people's boundaries or are bothering people in the chat, I will be having to kick you out of the meeting. So yeah, please make sure that you're respectful during this meeting. Thank you. I'm gonna go ahead and stop share, and our professional can go ahead and share her presentation and introduce yourself. Thank you.
All right, everyone. Thanks for having me. My name is Neena, Dr. Chandrasekaran. I am a pulmonary critical care doctor, internal medicine as well. I actually just graduated last week from Wayne State, so I'm here in Detroit. So why you see boxes behind me, because I will be moving back to my home, which is Florida, and that's where I will be practicing intensive care unit, ICU medicine, along with pulmonary. So a little bit about me. I went to American University of Antigua. That's a Caribbean medical school. And after that, I went to University of Pittsburgh Medical Center, UPMC, for my internal medicine residency. Graduated there and loved ICU pulmonary, which is why I went into my fellowship right after my residency here in Detroit. A total of 14 years of schooling if you include in undergrad, med school, residency, and fellowship, but completely worth it. A few things that I could say from my journey that have definitely helped me was getting involved early on. So everything that you guys are doing now from high school, getting these hours in, whether you're an undergrad or in high school or looking to get into the medical field, all of this really does play a big role, especially it sets you apart. So I do know that she was mentioning about the e-board that will look good on your application, something to do, and different ways to get connected. All right, so with that being said, today I'm going to be talking about Code Blue. So this is actually a very interesting entity, and it's something that we see a lot in the intensive care unit, and it's actually something that you might experience or have experienced once in your life. This is very interesting to me because this is actually what drew me into really loving intensive care unit. I was a med student in the hospital shadowing, and there was a code blue, and everybody rushed into the patient's room because the patient was, well, dead per protocol, as the definition of code blue, which we will go over. And it was such a mess. It was so chaotic. There were like 100 people, or it felt like 50 people in the room. Everybody was doing CPR, trying to save this person. And the person who was running it all was an ICU doctor. And it was at that point in my third year of med school that I realized I wanted to do ICU. So code blue, what exactly is it? You've probably seen it on TV, Grey's Anatomy, news, any type of show, or you might have experienced in real life somebody down on the ground and they can't breathe, they have no pulse. That essentially is the definition of code blue, or a cardiac arrest. So what we're going to go over today, what is a cardiac arrest? What does this mean? What are the causes of this? How do you treat it and how do you prevent it? So what is a cardiac arrest? This is a sudden unexpected loss of heart function, breathing, or consciousness. You need all three to stop in order to be deemed cardiac arrest or code blue. So this is when your heart essentially stops functioning. And what does that mean? The heart is the organ or muscle in the body that's responsible for giving blood throughout the body, including your brain, your lungs, all of your major organs. If your heart isn't functioning, your body isn't functioning. There's no blood going into essentially every area of your body. Now, there's one exception to this rule, and that would be ECMO, extracorporeal membrane oxygenation. That is a machine where your heart essentially is outside your body, but we're not going to get into that. So yeah, a code blue. If somebody's on the ground, they don't have a pulse, you can check somebody's heartbeat function through a pulse. The easiest way, you can get on the carotid. If somebody has a carotid pulse, they have an at least 70 systolic blood pressure. Blood pressure is measured with systolic over diastolic. We normally say 120 over 80. So if you put your fingers on the carotid and there is beating, then that is essentially, they have, by definition, 70 millimeters of mercury systolic pulse. Another way you can tell a pulse is if you go here and then you check their radial pulse. That's the most common method used. If you see on the ground somebody's down, they'll just check, hey, do you have a pulse? Do you have a pulse? That would, if you have a pulse here, that's anywhere between around 90 millimeters of mercury, because that's farther away from the heart, meaning the heart has to perfuse the blood into the radial artery. But the carotid is closer to the heart, which is why if you have that, you at least have that much of a blood pressure. Now, breathing. This is also an important function. Without the heart, there's no blood going into the lungs. So that, again, is part of the definition of a cardiac arrest. So if somebody has an unexpected loss of heart function, how does that present? It presents with various rhythms. And a rhythm is how the heart normally pumps. We say that there's four main ones that can cause a cardiac arrest. One is asystole. We'll get into each of these specifics, but these are the names. Asystole, PEA. Another name for, or the full term for PEA, is pulseless electrical activity. And then ventricular tachycardia and ventricular fibrillation. So we'll get into each of these. When you're assessing somebody for a cardiac arrest, such as when I am, if they're in my ICU, or if they're on the floors, or if they're on the ground, you do a full evaluation. You need to check their pulse, like we mentioned. You need to see if they're breathing. How do you check if someone's breathing? Well, one thing is the rise of your chest. Do you see their chest moving up? Do you see their chest moving down? You can also put your face essentially close to their face and see if you feel the breath moving in and out. So that's how you assess. That's part of the evaluation. And then the last thing would be mental status. The three things we mentioned: heart, lungs, and mental status. So part of the evaluation would be the mental status. You'll say, hey, can you hear me? What's your name? Can you answer? Do you know where you are? If they're completely out, if there's no blood going into their brain, they're not going to have much of a mental status at that point. So that's all part of the evaluation and the physical exam. The biggest things: always check for pulse, always check, are they breathing? You can look at it by chest movements rise, or you can feel their breath moving in and out. And then you assess their mentation, like we mentioned. Now, anytime you go into research, you're going to see cardiac arrest being mentioned in two different categories. One is OHCA, or out of hospital cardiac arrest. Out of hospital cardiac arrest can happen at any time. There's such an entity known as sudden cardiac disease or sudden cardiac arrest disease that can happen with a patient on the floor at home. I could suddenly cardiac arrest, God forbid. Anyone can, you know what I mean? It can happen on the plane, it can happen on the sidewalk, and that's what we call out of hospital cardiac arrest. These two terms are deemed differently in terms of prognostication for research purposes. And then the in hospital cardiac arrest usually has a better prognostication because you're in a hospital with healthcare workers who know CPR, BLS, ACLS, and are trained. Now, these are the 4 rhythms that we were talking about. There is asystole here, which essentially is, a flat line, asystole. A means nothing, like without, and then systole is a heartbeat, so without heartbeat, essentially. And you can see here it's just a flat line. Pulseless electrical activity. Now, this can look very similar to normal activity of your heart, but there's just no pulse. So your heart is essentially, it's beating, but it's barely beating. It's not beating like it should fully contract. It's just quivering. Then there's ventricular fibrillation. This is when instead of the heart beats coming from one specific area called the SA node, all the impulses are firing from all over the ventricle or all over the heart. So normally the way that the heart beats, this is a normal sinus rhythm. The way that the heart beats, first there's 4 chambers to the heart. I'm just going to skip over this to go to a picture. Okay, well, I guess I didn't have it. But normally the way the heart beats is you have your first ventricle, your first atrium. It's like 4 chambers. The first chamber will relax, get the blood, and then move it to the next chamber that will relax, get the blood, move it to the next chamber that will relax, get the blood. Now, what's happening here is when the blood accumulates in that first chamber, it starts by an electrical impulse. And what's happening here is that electrical impulse is coming from many areas. And that's why it's giving this weird pulse. There's no relaxation. There's no depolarization, essentially what we call it. There's no relaxation. There's no time for blood to fill. It's just shooting. So it's not performing a proper contraction like we would want here. It's kind of, again, quivering essentially. Pulseless ventricular tachycardia is when the heart is beating so quickly that it's not filling. Again, it's just going so quickly that it's not having time to fill. Nothing is happening. And if it's not having time to fill, then no blood is going out. It's all kind of just remaining in the front area of the body and not moving forward and perfusing all the organs. So that's, and the reason that we would know this is the reason that we would know what type of rhythm it is once they're down on the ground, we would hook them up to pads, and then we'd have a monitor, and that monitor would tell us, is this VFib, is this pulseless VTach, is this PEA, or is this asystole? If a patient has this activity, but they have no pulse, then that's PEA. And this is important to know what rhythm it is, because that's the difference between, do you defibrillate early on or not, you don't. If you defibrillate, it won't do anything. So VFib, we talked about VFib a bit, ventricular fibrillation. So this is a chaotic rhythm and rate. Like we mentioned, from the heart, there's different impulses just firing all at one time. Disordered electrical activity causing the heart's lower chambers or ventricles to quiver, like we mentioned. So instead of pumping like a normal heart should pump, like pump, it's just quivering, it's quivering. Nothing's moving forward if the heart isn't pumping. Nothing's moving forward, then no blood is moving forward. No blood is going to your brain. No blood is going to your liver. No blood is going to your kidneys. No blood is going to your lungs. So that's how that forms the cardiac arrest. And this is important. And then the other one that we'll talk about before we talk about defibrillation is pulseless VTach. So pulseless VTach, again, like we spoke about, it's the heart beating very quickly. So the electrical impulses, like we mentioned, normally there's one part of the heart and that part has to signal. Once that signals, one whole pump or a contraction will happen. This is very similar to VFib in that it starts shooting impulses super quickly, to the point that the heart keeps pumping, but it becomes so quick that it's not pumping properly. It's not having one big squeeze or contraction. Instead, it's quivering again, and it's just trying until it gives out. So that's VFib and VTach. Now, it's important to know VFib, VTAC, and distinguish them from asystole or flatline and pulseless electrical activity, because defibrillation, we mentioned that the impulses in the heart are shooting from different areas. So the treatment or fix, we say usually to that, is a defibrillation. So once you put the paddles on the person and charge to like 360 joules, you're giving an electrical impulse to the already electrical impulses that are shooting from all over. And that essentially should fix the conduction system, is what we say. So that's why if it's a VFib or VTAC, the first thing we try to do is get pads on them as soon as possible and shock. And that's the defibrillation. Now, that's different than asystole or pulseless electrical activity. The reason is because there's not a bunch of impulses being shot from different areas of the heart, causing the asystole. As you can see here, that's the case here, but not the case here. This just means the heart is not pumping, and then the heart is not pumping due to many reasons, which we'll get into soon. So again, with VFib and VTAC, you try to get the pads on them as soon as possible. One goes in the front and the other goes in, one goes in the front anterior and one goes lateral, and then you shock. So that's normal. In order to know abnormal, you have to know normal. So this is normal. Again, like we talked about, there's the atria, the top of the heart that relaxes, pulls all the blood together, and then the blood moves. It relaxes, gets the blood, relaxes, gets the blood, and then it pulls together. This is normal. Asystole, we mentioned that's a flat line. That's like you'll hear people on shows or something go, patient is flatline, flatline. That means that there is absolute no movement within their heart. There is complete cessation of electrical and mechanical activity of the heart. In VFib and VTAC, the heart was still trying to quiver. There were still impulses going. In asystole, that none of that's happening. There's complete cessation. Now, asystole can happen with after VFib and after VTAC. The heart can become so done and tired, and it just kind of gives out to the point that it can get into asystole. So these two can turn into asystole. Now the treatment for, if this is an out of hospital cardiac arrest or code blue in general, we mentioned a few things about a physical exam. One will be, does the patient have a pulse? And the other will be, is the patient breathing? And then the last will be their mentation. The first thing you do when you do see this, if you're out of a hospital or sometimes even in the hospital, you jump on their chest. You go to where their heart is located, which we say is mid-clavicular. And then we say like fourth or fifth intercostal, and then that's where you feel the heartbeat, and then you start doing compressions. This is an example of what we call CPR, or cardiopulmonary resuscitation. Now this is kind of an algorithm that we go through when you do ACLS or BLS. You become certified in this, and you can help assist CPR, or you're CPR certified. The first thing that you want to do, so this specific algorithm is for COVID-19 or pediatric cardiac arrest, similar to a lot of the other algorithms out there. The only difference between a COVID algorithm and a non-COVID algorithm is prior to doing a COVID algorithm or COVID CPR, you have to gown up. Gown up with the PPE is what we're talking about, where you have your N95, you have your PAPR on if you can, you have your gown on, your yellow gown, and you have gloves. Ideally, you should have gloves as you're doing CPR and goggles in case you're doing CPR and the person vomits. I've definitely had that happen before. Not fun, but usually that's a little hard to get. So anyways, you go to the room and somebody is down. Code blue is called. What do? You jump on their chest, you try to get them hooked up to the monitor as soon as possible so you can see what type of rhythm it is. If you can't see what type of rhythm it is, you still continue with CPR. The main goals of CPR is to essentially obtain ROSC. ROSC means return of spontaneous circulation. And that would mean that the goal of CPR is ROSC, return of spontaneous circulation. And that's when the heart is again perfusing. So once the heart is back to perfusing, or back to giving blood, back to contracting like it normally should, you have achieved your goal or what you are trying to do with CPR. CPR, we say that there's compressions, airway, breathing. So CAB is the normal algorithm, and sometimes it can be ACB, or airway, circulation and breathing. Airway is most important. if it's a PEA or asystole, because the most common cause of asystole or PEA is hypoxia or no oxygen to the heart, and that can cause a PEA or asystole. We'll go over why somebody does get into a PEA or asystole. So the main things while you're doing CPR, you're trying to figure out, is there a reversible cause? Why did this person arrest to begin with? If it's an out of hospital cardiac arrest, it's very difficult. You gotta, these are memorized. They're like imprinted in my head because I've been doing this now for a while. But the major things will always be there. So these are what we call H's and T's. This is something that you learn as you do your ACLS or BLS. So H's, there's hypovolemia. That means that somebody can just be super dehydrated. They can be on, maybe they're on water pills and they just have no fluid inside of them. Sometimes there's like a fine balance between how much blood should be in your body and how much should be out, or fluid should be in your body. Sometimes if some people just don't have any fluid, they haven't been eating or drinking for a very long time. They're, I don't know, on a hunger strike or something. They lost a lot of blood through hemorrhagic shock, or like somebody cut them and they bled out. That's what we call hypovolemia. So if there's nothing to go into the heart, there's nothing to go out of the heart. Essentially is how I look at it in terms of the hypovolemia being the first cause of a cardiac arrest. Now that's a quick fix. You kind of pump them up with fluids. You give them fluids. If it's bleeding loss, you give them blood. You give them what they need. Hypoxia. So this is what we were talking about when we spoke about asystole or PEA. That's when there's no oxygen going to essentially the heart. And this can be a cause of many reasons. One can be tamponade, one can be hole in the lung. Tamponade is when there's fluid around the heart and the heart can't pump. Another can be trauma. Another can be a major clot in the lungs that's preventing the airways from breathing. A lot of causes of hypoxia. But essentially the fix for hypoxia is, you've probably seen this on shows, somebody tries to breathe into the other person's mouth to give them oxygen, to make that oxygen go through their trachea and into their lungs. Because once the lungs start getting oxygen, that can then go into the heart. Essentially, what we would do in the hospitals, we'd start them on nasal cannula, crank up the oxygen, or we would intubate them. By intubating them, we would place them on the mechanical ventilator, and that would provide them with oxygen. So essentially, their lungs would get a break, and they would be getting oxygen from a ventilator. So that's usually the fix for hypoxia. Hydrogen ions. This is acidosis. If somebody's body is super acidotic, meaning their normal body lives in a range with a pH of 7.4. So there's a certain amount of base in the body and a certain amount of acids in the body. When this buffer gets thrown off to the point where there's a lot of acid, this can destroy cells. It can cause cell death, cell apoptosis, like we like to call it. And this destroys the cell apoptosis or cell death can happen within the conduction channels of the heart, and that can cause the heart not to, again, contract normally. Hypokalemia. So potassium is a very, very, very important electrolyte within the body. You can get potassium by eating bananas and by eating certain other types of food. Potatoes too has a lot of potassium. If it's too much in the body, that can lead to this VTAC or VFib. And the way it does that is because in the heart, there are specific channels, and these channels are regulated by potassium. So if there's too much potassium, you're throwing off the balance of the channel. If you throw off the balance of the channel, the heart can't function or squeeze the way that it normally should. So watch how much potassium you eat. Don't be eating too many bananas in a day. And then sometimes too low potassium can do that too. Now you can lose potassium with things like diarrhea if you take any of those over-the-counter digestive meds, or those things that people take to go on detox cleanses. You would essentially poop out all your potassium. Hypothermia. So somebody's super cold, that can cause a cardiac arrest because the body, again, isn't in its normal metabolism regulation as it should be. Hypoglycemia. So if you have too much low glucose, if your blood glucose is super low, which diabetics sometimes can face if they're taking insulin, or if somebody just hasn't eaten in like a few days, then their glucose being low can cause their heart not to function. And this has to do with the channel regulation as well. Toxins and tablets. Now, there's some toxins that if you overdose on, that can cause cardiac arrest, some type of meds. Tamponade, we briefly mentioned that. That's when there's fluid around the heart. If that fluid becomes too much, that can prevent the heart from pumping, because the fluid, the heart is being bombarded and it's not being able to stretch and close like it normally should be because of the fluid. That's what we call tamponade. The fix for tamponade is taking a needle and then going into that fluid and just releasing it. Tension pneumothorax. That's when you have air in the lungs, and that prevents the lungs from breathing in and out. And that can cause hypoxia, which can then cause a cardiac arrest. Thrombosis, or a heart cardiac arrest, or well, an MI essentially. So this thrombosis can be fatal. Now, thrombosis can lead to VFib or pulseless VTAC or VTAC. VFib or VTAC is usually what we do see from a myocardial infarction. You can see asystole, but most likely VFib or VTAC, pulseless VTAC, is what we think about when we think of a heart attack. And the reason is because the definition of a heart attack is essentially a blockage of one of the main arteries of the heart. One of the main arteries supplying the heart is blocked off. So blood normally flows, blood can't flow because there's a blockage. Now, what causes the blockage? Is it atherosclerotic plaque, meaning or is it a cholesterol plaque? Is it just a bunch of fatty lipids that's doing it? Whatever the cause is, that will lead to blood stopping to go into the heart, and will lead to the heart trying to compensate by shooting signals from different areas of the heart, hence leading to VTAC or VFib. So that is thrombosis or heart attack. Can you drop dead from a heart attack? Yeah. And then thromboembolism. It's another type of thrombosis, but it's not to the heart, it's to the lungs. If you get a major blood clot to a major pulmonary branch, then that can stop blood from going, it can stop major oxygenated blood from going into the body, and then that can lead to hypoxia, which can then lead to PEA or asystole. And then of course, trauma, any type of trauma. If you hit yourself, if you go into an MVA versus passenger collision, motor vehicle accident collision, that's the MVA, then you can hit yourself on the passenger, like this bag that comes up that can cause a contusion to the heart. That's usually what we worry about with the airbags. Once they do get released, if you go back and forth like that, that can hit the heart and cause a pulmonary or myocardial contusion, which is essentially a bruise of the heart or a bruise of the lungs. And that can lead to bleeding within. Various reasons why trauma can do it. But these are the main causes of a cardiac arrest. So again, like we mentioned, CPR is what you would do the minute you see a patient or somebody on the floor who has a cardiac arrest. ROSC is the goal of CPR. So return of spontaneous circulation. And then after return of spontaneous circulation, that would sometimes usually be where I come in, me as an intensive care unit. So a lot of the times these patients get resuscitated in the emergency room, the ER. I deal with them if they're my patient, they came in a cardiac arrest, and then the ER calls me and tells me, hey, it's patient's here. Then I'll go down and run the code, is what we call it. Or if a patient's on the hospital floors and then they call me, I will run the code. By running the code, I mean I do this algorithm. I say, all right, what's the rhythm? That's usually the first question. Well, first question I ask is, does this patient have a pulse? And then, because sometimes somebody might not feel the pulse, but somebody else might feel the pulse. And then you always get a glucose, because you want to finger stick check them sometimes. If it's a simple fix, like we talked about here, the H's and T's, if it's a simple fix where somebody got too much insulin, or somebody's been in the hospital for like 5 days and they just don't like hospital food and haven't been eating, then maybe all they need is just like orange juice, and then they'll pick up. So I say my first few questions when I walk into the room, I'll say, does this patient have a pulse? What's the blood glucose? Those are the first two things I ask. And then what's the rhythm? Because I need to know the rhythm in order to know in my head what I'm thinking. And again, you have to know if it's one of these rhythms to defibrillate or not defibrillate. If it's asystole, I would say get the pads on them, but don't shock them. If it's VFib, I would say get the pads on them and shock them now. And that's why it's super important to know the difference. So once the code is run, whether it's me running the code or the ER running the code or somebody else outside running the code and ROSC is achieved, we go into post-arrest investigations. And this means, why did the patient arrest? Very simple. So a glucose, like we mentioned, to get a finger stick glucose, see what their blood, if they have been eating, if that's the reason they arrested. Then you go on to your basic labs. Your sodium, your potassium. Your potassium, we said, is a very big one, very important, potassium. Sometimes when we do it, we see potassium being like 9. A normal should be below 5. We say 3.5 to 5 is a good range for your potassium. Normally, ideally, we would like 3.8 to 5, but as long as it's within that range, you should not be arresting from that. CBC, so that will check your hemoglobin, your red blood cells, your platelets. INR, that's a coagulopathic panel. You'll get liver function tests, because sometimes if somebody's a chronic alcoholic, they can code to, from various reasons, lactate troponin. Troponin is a very, very important one in our algorithm as to post-arrest investigations. Glucose, potassium, and troponin are 3 major ones. The reason glucose is because we spoke about it. If it's too low, that can cause you to arrest. Potassium, we spoke about it. It has to do with the channels within the heart. So if it's too much or too little, it can cause cell death. The cell death will then not allow the heart to pump properly. And then the last one is troponin. Troponin is very important. Well, that's the last one of the 3 main ones. So troponin is very important because it's an enzyme that's leaked when the heart is damaged. So it can be leaked from other organs as well, but a very high troponin means that the heart is not functioning properly. Something has happened to the heart. For example, if I had a patient and the ER called me and they're like, hey, we got ROSC or return of spontaneous circulation. Patient came in 13 minutes ago. It took us 10 minutes to revive her, and now she's alive. The troponin, I would ask for that, and if it's like 1,000, I would be like, okay, in my head I would be thinking this person had a heart attack, because for that to be that elevated. Now, as you are doing CPR, some of these labs are definitely going to be off. When you're doing CPR, you're essentially doing it to make the heart pump again. So you are breaking ribs, you are breaking cells, and as you do break cells, you do the cells lyse and they do release potassium. So the first potassium might be falsely elevated. Troponin can be elevated post-arrest as well, because we are pushing on the patient's heart. Essentially, you're causing a troponin leak, but it depends to the degree of how high it is. Do you think in your head, is this a heart attack? The reason it's important if you suspect heart attack to know that right away is because then the patient will need intervention. The patient will need to be taken to the cardiac arrest or the cath lab. And like we said, that a heart attack, the definition is when a blockage is there in the heart. You need to open up that blockage. That's the fix. The way you open up the blockage, it depends. Is this one artery that's blocked? Is this 4 arteries that are blocked? That can determine if you need a CABG or like a open heart surgery, that's CABG, bypass graft, a cardiac arrest bypass graft, or a PCI, or like a stent. A stent is just, it's a metal piece that's about this big, and it just goes into the artery and keeps the artery open so blood can flow. It bypasses the plaque, and it keeps the artery patent or open. So again, the point is so blood can go. And that's the treatment if you have a heart attack. Besides the aspirin and the Plavix, the blood thinners that you should be giving to. Other things that are important would be blood cultures, procalcitonin, and that's for concerns of infection, because sometimes infections can cause arrest. It's very important to know if the patient's pregnant. Now, to know if the patient did have a heart attack, you always do an EKG. An EKG, there are things on there that you would look at to see if a patient did have a heart attack or not. We say ST elevations, so STEMI is what we call it. Now, ST is here, this here. You see that here that it's not elevated or it's not complete straight lines up. And somebody that has a STEMI or a ST elevation heart attack, ST elevation MI, their rhythms would be, it would just be a straight line up. So EKGs can tell us a lot of important information. We usually repeat the EKGs multiple times. We don't just get one. We'll get one, then we'll get one like 4 hours later, and then another one maybe 12 hours later, just to make sure that an MI did not develop after, or an MI was silent and we were missing it. POCUS. So ultrasounds are now becoming the big thing in the past 5 years. It's very easy to do. You can hook it up to your phone. You can hook it up to the ultrasound machine. It's just like a probe and you take it to the lungs. And this can tell you so much information. It can tell you if there's air in the lungs, like we spoke about the pneumothorax. It can tell you if the heart is failing, if the heart is pumping properly or not. It can tell you if there's a big clot in the lungs. And then other thing you do, very important, CT head, and we'll go into this a little bit. And then a chest x-ray. Chest x-ray is just something we do to see, again, if there's a pneumothorax. Sometimes there's fluid in the lungs, or there's a big raging pneumonia that can help us out. So this is, again, talking about why we kind of do what we do. So we mentioned we do the EKG and the echo, and these can tell us kind of the etiology, or it can help us determine the etiology or why the patient went into cardiac arrest. So we mentioned about if the arrest is due to an MI, myocardial infarction, or heart attack, we do call on the heart doctors to take them to the cath lab. And when they go into the cath lab, they will go in with a scope and look, a fluoroscopy, and look at all the arteries to see if there's a blockage. And we said there's aspirin, Plavix, the heparin, the blood thinners that you give a patient. Now we try to keep the MAP goal. This is what we call MAP goal, mean arterial perfusion, or a blood pressure. We try to keep that on the higher side. This is immediately post-arrest. And by immediate, I mean within 24 hours. Like if the patient arrested, it's 8:08 now, or here at least Eastern Standard Time. The patient arrested at 8 p.m. for the next 24 hours, we keep their MAP goal or their
You guys can go ahead and put your questions either in the chat or you can unmute, but please make sure that you remain respectful. Thank you. Awesome. Thank you so much for being with us today. So I'm going to go ahead and actually share our wrap-up presentation. So one moment as I do that. In the meantime, you guys can go ahead and put in the chat one thing you learned from the presentation today. Technical difficulties. It doesn't normally take this long, guys. Let's see. Awesome. Okay, so you can go ahead and answer more of these questions in the chat. So what are 3 major takeaways you got from the presentation and what else you want to learn more about? Once again, if you want some more recognition, you can write articles, reflections, reviews, success stories, and you can go ahead and submit them to our /blog submissions found on our website. And if you're interested in being part of pre-health shadowing, you should be able to find the links in the chat if you scroll up a little bit, but we are always accepting volunteers and we're currently looking for team members. And if you can, we would highly appreciate if you could donate to us. This is the QR code because we do run solely off of the time of our amazing volunteers as well as the donations that we receive. Now that we're at the end of our session, there's a simple 10 question multiple choice quiz that is based on this presentation, and you'll be able to find it on our website. You need to get at least a 70% or higher, and you have 2 chances, and this is what the certificate typically looks like. And if you miss any part of the session today, you can go ahead and visit our YouTube channel at Pre-Health Shadowing to watch any of our previous sessions for free. And be sure to catch our sessions every week so that you don't miss any of them. But yeah, see you guys next time. Thank you for joining Pre-Health Shadowing. And if you have any questions, feel free to stick around and ask the student team.